Good afternoon, everyone, and thank you for participating in today's webinar on workers' comp OMFS, fees, methods, and regulations, hosted by Daisy Bill. I'd like to give you a brief background on our presenter today, Sarah Moray. She has broad experience in workers' compensation and medical billing, about over 10 years, ranging from ground level experience in medical practices to consulting to co-founding both Clarity MBR and Daisy Bill. Daisy Bill builds web-based billing technology designed to manage the complexities of California workers' compensation billing. Daisy Bill is the only billing software built from the ground up to completely manage the entire workflow of California workers' comp bills. So before we get started in the webinar, I'd like to inform you that everyone is going to be on mute. If you have any questions, please type the questions in on the side panel questions tab, and Sarah will answer your questions at the end of the presentation. And I'd like to start you off with a few poll questions. If you would just take a quick moment to answer those questions, we'd appreciate it. And here you go. Give you about 4 more seconds there. Okay, on to the second poll question. Give you another 4 seconds or so there to finish up. And we'll go on to the last poll question. Okay, we'll go ahead and close the poll questions, and we'll review those answers with you at the end of the presentation. And I'd like to go ahead and hand it over to Sarah.
Thanks so much, Veronica. I'm really pleased to be presenting this webinar on the official medical fee schedule, the OMFS, to you today. It's really great to partner up with an organization like Physician Partners, and I hope this webinar is really helpful in understanding more about the fee schedule. Oops, hold on one second. There we go. So as Veronica mentioned, I am the co-founder of Daisy Bill, and we like to start all of our webinars with the mandated life cycle of a work comp bill. Now, SB 863 dramatically changed the landscape of workers' comp in California, and it's really important that all parties understand their mandated responsibilities under SB 863. Now, part of SB 863 included the adoption of the RVUs-based physician and non-physician official medical fee schedule, and again, that's abbreviated as the OMFS. And under SB 863, as of last year, starting on January 1st of 2014, both the method to calculate the reimbursement as well as the actual reimbursement amounts dramatically changed for services rendered by physicians as well as non-physicians. And then now, as of March 1st of 2015, the method of determining the reimbursement is the same, but the amount of the reimbursement has changed for all physician and non-physician services. So today I'm going to explain in detail what these changes are. And then to give you an idea of what to expect, this is a roadmap of what we're going to cover. The start of this webinar is going to be a bit more technical. And then after the technical component, we're going to cover applications of the OMFS to reimbursement for things like J-codes, to surgeries for physical medicine and radiology. And then with the end, we're going to cover the second bill review process as well as updates that are going to be coming effective on July 1st of this year. So that was some new information that just came out last week. So we're lucky that we're having this webinar now, and I'll tell you a little bit about those changes. So let's dive in. Everything that we are going to discuss today can be found on the DWC's OMFS website. And if you click the Physician Services link, and that's circled in blue on this slide, you will be directed to the section of the web page that specifically deals with the Physician Services Fee Schedule regulations. To download the new fee schedule changes that took place back on March 1st, you can click the clean copy of the regulations, and that little blue arrow is pointing to the exact location of the clean copy. You know, sometimes it's a little bit hard to find exactly what you're looking for on the DWC's website, so we're giving you the precise location that you can download it. So to get started on the actual fee schedule calculations, I want to spend just a couple of minutes looking back over time at the history of the physician fee schedule. So let's start with 2 years ago. Let's start with a 2013 date of service, which you can see at the top of the slide, for the common E&M code 99215. And back in 2013, the OMFS reimbursement rate was $129.41. Now, our technology includes an OMFS calculator that provides historical reimbursement rates. So that's what I'm going to be using just to show you what these fee schedule rates are. In the 99215 example that we're showing here, for the date of service in 2013, the reimbursement amount can be found in Table A, and that's in section 9789.11 of the official medical fee schedule. And you can also see for this date of service that the reimbursement rate for 99215 had been in effect since 2007, so for a long time. In the past, before SB 863, DWC's Table A could tell everyone easily what the exact rate was per the official medical fee schedule. But for the new RVRVS-based fee schedule, the DWC doesn't publish something like this. Instead, you're responsible for determining the correct reimbursement using the calculations that I'm going to go over today. So per SB 863, for all dates of service as of January 1st, 2014, the physician services fee schedule changed to the RVRVS-based calculation that I mentioned before. And so we're going to continue to use this 99215 procedure code as our example. For a date of service as of January 1st, 2014, the 99215 reimbursement was $167.15. And with the adoption of the RVRVS-based fee schedule on January 1st of 2014, it increased quite a bit. So from $129.41 up to $167.15 for services that are provided in a non-facility by a physician. So now for the same 99215 procedure code for a date of service as of March 1st, 2015, so just a couple of months ago, the new reimbursement increased again to $178.59. So remember, before we were at $167.15, now we're up to $178.59, excuse me. And this is over a 6% increase in the reimbursement rate, so quite a bit. As I mentioned before, the RVRVS-based reimbursement rates are not published on the DWC's website. There is no Table A equivalent showing that OMFS rate. So instead, to calculate the reimbursement rate for all physician and non-physician services, the OMFS regulations provide two formulas that must be used to calculate. The formula on the left is for reimbursement in a non-facility, and the formula on the right is for reimbursement for services provided in a facility. Now, since the DWC doesn't publish those reimbursement rates, at Daisyville we think it's really important that the workers' comp community understands how to calculate these reimbursements precisely. So we're going to walk through all of the different components of the calculation using this 99215. There are three separate components, and they're highlighted in yellow on this slide. The first are 3 RVU types, with each RVU type assigned an RVU value. The second component are 3 GAFs that correspond to those 3 RVU types. And then the final component is a single monetary conversion factor. And in our calculator, by clicking on the detailed information arrow that's circled in red, kind of in the center on the left-hand side, the calculator shows all of these underlying categories, the RVUs, the GAFs, and the conversion factors that are associated with all of these procedure codes. Now, for all dates of service as of March 1st, the DWC adopted completely new values for all of these components, those RVUs, the GAFs, and the conversion factors that I mentioned. And these new values are found in the regulations under section 9789.19. And that's the part of the regulations that are called the update table. And in the update table, there are two subsections. Subsection A, and that's highlighted in blue on this slide, contains the documents for services that are rendered on or after January 1st, 2014. For services that are rendered on or after March 1st of 2015, there's a new subsection, which is subsection B, that's highlighted in yellow on this slide, and it contains all of those reference documents that are applicable to those dates of service after March 1st. It's a bit tricky because the new reimbursement rates are not contained in subsection A. So as you scroll through the regulations, when you come to subsection A, don't look at that if you're looking for a date of service after March 1st. You need to look in subsection B. And just as a tip that's circled at the bottom, that subsection B starts on page 64 of the regulations. So to help you understand these March 1st reimbursement changes, I'm going to spend just a few minutes walking you through the new RVUs, GAFs, and conversion factors. And we're going to start with a non-facility fee calculation, and that's the one on the formula on the left-hand side here. For all dates of service as of March 1st, in the update table under subsection B, there is a link to the newly adopted CMS Medicare National Physician Fee Schedule Relative Value file. It's quite a mouthful there. And when you click on the link there, you'll be taken to the CMS website where you can download a file of all of the procedure codes. In that linked RVU file, each procedure code is going to have an associated work RVU value, a practice expense RVU value, it's known as a PE RVU value, and a malpractice expense, it's known as ME RVU value. And then for our example, 99215, this slide shows the changes in the RVUs as of March 1st. The green circle on the top is the RVUs that are effective for 2014 and forward, and then blue on the bottom is effective March 1st, 2015 and forward. As you can see, the work RVU remained the same at 2.11, but the PE, practice expense RVU, increased from 1.79 up to 1.82. And the ME RVU increased from 0.13 to 0.16. So that's just part of the formula that helped with increasing that reimbursement for that particular code. And as I mentioned before, just like Medicare, the OMFS reimburses a different amount if the services are delivered in a facility. So on the right is the calculation for payments that are, or I'm sorry, for services that are delivered in a facility. And the facility site calculation uses the facility practice expense RVU to determine the payments for services that are delivered at a facility. Now, in section 9789.12.2D of the OMFS regulations, there is a table listing the types of places of service, and each place of service is designated with either an F for facility or an NF for non-facility. And here's just a partial list of the places of service that are listed in the table. Facility RVUs are used where the place of service is listed as a facility, F, and non-facility RVUs are used where the place of service is listed as NF for non-facility. And it's important to note that the place of service code is used to identify where the procedure is furnished. So all services that are assigned the place of service code for the setting in which the patient received those face-to-face services. Now on this slide, you can see that the E&M 99215 reimburses $134.10 at a facility. And if you recall, at a non-facility, it was $178.59. And this is because the facility practice expense RVU, highlighted in yellow, is 0.87. So that's a lot lower than the non-facility practice expense RVU of 1.82. The 3 GAFs that correspond to the 3 RVUs are the second component that's used in the calculation. And GAFs stand for Geographic Adjustment Factors. And you can see on this slide that for the reimbursement calculation, each RVU type has an associated GAF that's used to calculate those reimbursement amounts. And remember, those GAFs change as of March 1st. Those are those 4 new GAF rates. And then again, that update table in subsection B lists those new GAFs that are effective for March 1st and forward. And for those of you that are familiar with Medicare billing and Medicare reimbursement, the average statewide GAFs are the equivalent to the Medicare GPCIs. Those are the Geographic Practice Cost Indices, and there are 10 of those. So the OMFS doesn't use GPCIs. GAFs are used in place of GPCIs. Now in this example, circled in pink, you can see the GAFs in action. The work RVU, which is 2.11, is multiplied by the statewide work GAF of 1.042. The practice expense 1.82 is multiplied by the practice expense GAF of 1.1621. And then the malpractice expense RVU 0.16 is multiplied by the malpractice GAF, which is 0.7388. And for the 99215, again, this slide shows the change in the GAFs from January 1st, 2014 to the change on March 1st of 2015. So green is for the old dates, and then blue is for the current dates. Now the 99215 calculated for a facility place of service is on this screen, and you can see that the calculation uses the same GAFs as the non-facility. So the only difference in the calculation for services that are delivered at a non-facility and a facility is the non-facility uses the practice expense RVU. The GAFs don't change based on the place of service. Now the last step in the calculation is to determine the reimbursement. Is the conversion factor. And for those of you that are familiar with Medicare, again, you know that there is a single monetary conversion factor which changes every year. And instead of having that single conversion factor, California Work Comp has 4 separate conversion factors. Those are shown on this page. As of March 1st, they changed again, and these new values are found again in the update table in subsection B. And highlighted in blue here, you can see the 4 conversion factors that are effective for 1/1/14 and forward. And then the yellow are the conversion factors that were effective March 1st. There are 4 different conversion factors, as I mentioned. And because in workers' comp the conversion factor is selected based on the type of service that is rendered, that's why there are those 4 different conversion factors. And those 4 are anesthesia, surgery, radiology, and then other services. Now for the 99215, since it's classified as an other service, we show that effective March 1st, the conversion factor is 40.2970, which is circled in blue here. This slide compares the change in the conversion factor and the reimbursement rate for the dates of service for January 1st, 2014 and forward, and then the change that took place on March 1st. So for the dates of service for 2014 and forward, the top calculation shows the conversion factor of 38.3452. And then it changed, it increased up to 40.2970, which resulted in helping that increase in reimbursement up to 178.59 for this particular code. Now remember that for work comp, the conversion factor is selected based on the type of service rendered, and there are 4 types of services. So let's take a look at a different procedure code, a 64718, and it compares the change in the surgical conversion factor and the associated reimbursement rates for a date of service in 2014 versus March 1st of 2015. The top calculation, which is circled in green, is for the date of service January 1st, 2014. It shows that that surgical conversion factor is 55.2913, and the reimbursement for the procedure code is for the 64718 is 995.13. Now the bottom calculation is again that surgical code of a 64718, and it shows the surgical conversion factor of 51.6570. and the reimbursement is now reduced to $943.11. So that one did get reduced when it changed in March. And similarly, here is a radiology calculation for a 72148, and you can see the conversion factor of 53.1039 up there in green. And then the blue notation on the bottom points out that effective March 1st, the conversion factor for radiology decreased to 50.1900. So the reimbursement is also decreased. So we're done explaining the two formulas that must be used for every procedure code. So just to quickly review, in order to calculate the reimbursement for services provided in either a facility or a non-facility, the procedure code's correct RVU values, effective for the date of service and the place of service, are multiplied by the statewide average GAFs, and then that subtotal is multiplied by the conversion factor that's effective for the type of service. So we're now about the midway point, a little over the midway point. We've gone through the methodology, but now we're going to cover some other factors that affect the reimbursement along with those associated regulations. Remember that for all dates of service as of March 1st, in the update table under subsection B is the link to the CMS Medicare National Fee Schedule relative value file. And that takes you to the CMS website where you can download a file of all of the procedure codes. Now, in addition to containing the RVU values for each procedure code, it also has the associated status codes for each procedure code. So what Work Comp has done is adopted the Medicare status codes, but California assigns a different definition to each of these status codes. I'm showing an example of this Daisy Bill calculator again, and you can see that this has a status code, this procedure code 99215 has a status code A. Most codes do have a status code A, which means that they're payable under the physician fee schedule. And you can see that definition at the top of this screen. Procedure codes that are assigned a status code B are not payable. The OMFS regulations define procedure codes with a status code B as bundled codes. And that definition states that even if the procedure code has an RVU value, you do not use the RVU values to calculate the reimbursement. Now, a good example of this is a 99358. That's probably a code that a lot of you used to use. And a 99358 now has the status code B. And so you can see from the calculator that even though it has RVU values and the reimbursement could be $131.98, because it has a status code B, it is a bundled code and is not payable per the fee schedule. Now there are 13 different status codes and each of them has its own definition. So if you are doing your own calculations, make sure that you are up to date on all of these status code definitions and that you're calculating those reimbursements correctly based on that definition. Now, work comp obviously has a lot of things that are very specific to work comp, and the OMFS includes California-specific codes which are used for reimbursement of things like reports, duplicate records, duplicate x-rays, and scans. And for all dates of service as of March 1st, 2015, the California-specific codes increased by 1.008%. And this change resulted in a small increase for each of those California-specific codes. And a good example of that is the PR2 report, a very common report. It increased from $11.91 up to $12.01. And here's a question that comes up a lot. What about consultation reports? How are they billed and how are they reimbursed? Prior to the RBRVS-based fee schedule, a code 99080 was used. But you can note on this slide that a 99080 is a status code B. And remember that the status code B means it's not reimbursable. On the right, note that the section 9789.14 of the regs indicate that consultation codes are payable only when requested by the WCAB, the administrative director, or by a med-legal provider in the context of a med-legal evaluation. And if a report is requested by one of those entities, don't use the 99080. Use the California-specific code WC007. And the WC007 description in the regulations is really critical, along with the appropriate modifiers to use when billing that code, the WC007. A consult report, remember, is only reimbursable when it's requested by the WCAV or administrative director, or when it's performed in the context of a med-legal evaluation. So unless the actual consult visit meets one of these classifications, the report is not reimbursable. Now, we receive a lot of questions regarding physician-administered drugs, and on the right-hand side of this slide is the specific section of the regs that deals with the reimbursement of J-codes. And circled in blue, this section of the regulations is noted in the status explanation. The reimbursement amount for J-codes is determined by the monthly release of the Medi-Cal rates file. And it's important to note that that's monthly. So on the 15th of every month, the DWC adopts the new rates for the J-codes. So we're now about 2/3 of the way through the webinar and just a little bit more to go. I want to focus just briefly on some of these ground rules that affect the reimbursement calculation. And then we're going to talk briefly about the second bill review process. So I first want to talk about the global surgery billing requirements, and part of this section references that ICD-10 will go into effect in California for California work comp on October 1st. So don't delay on getting prepared for that. Make sure that you're prepared for ICD-10. And then with the adoption of the fee schedule back in 2014, the physician fee schedule regs adopted the multiple procedure cascading reductions. So when multiple surgical codes are billed together, the highest valued procedure code is reimbursed at 100%, and then subsequent valued procedures are reimbursed at 50%. And you can see that example here. The top code is paid at 100%, the bottom code is paid at 50%. And multiple procedure reductions only apply to the surgical procedure codes that are designated a 2 in the multiple procedure column of the Medicare RVU table. So it's not enough to just know what the full reimbursement is and take 50% off. You have to know that that specific code has a designation of 2. Not all procedure codes surgical procedure codes have that designation of 2. And here's an example of that. Both of these codes are paid at 100% because only the top code is able to be cascaded. And since that is the highest valued code, it is paid at 100%, and the lower valued code has no cascading rules applied to it because it's not valued a 2 on the multiple procedure column. So be sure to look out for those details and calculate those cascading rates appropriately. Now, as of March 1st, and then again through 2 updates, one of them that happened in May and then the other one that's going to happen in July, there is a new Medicare file that indicates which physical therapy and physical medicine codes are subject to multiple cascading reductions. And physical therapy codes are another example of a set of codes where multiple reductions do not apply to every single code. And here are 2 codes that are subject to the physical therapy multiple procedure reductions, a 97001 on the top and the 97110 on the bottom, and that's circled in blue. And note in the ground rules section of the calculator when the reductions are applicable, and it's not the entire value of the code that's reduced when those reductions are applicable. Only the practice expense component of the code is subject to the 50% reduction. In this case, the second code on the bottom is circled in blue, is the one that's subject to the 50% physical practice expense reduction. And when this is calculated, the reimbursement is $29.70 as opposed to the 100% value of $40.09. So make sure not to make the mistake of reducing the entire reimbursement by 50%, only the practice expense component. Multiple procedure reductions apply to some radiology codes as well. And believe it or not, this is even a little bit more complicated than both the surgery and the physical therapy multiple procedure reductions. So let's briefly look at how it's applied. The radiology reimbursement is comprised of a professional component and a technical component. And in order to apply the multiple procedure reductions, the full reimbursement for each component must be known. The highest component is paid at 100%, with the subsequent professional components paid at 75%. The technical component with the highest value is paid at 100%, with subsequent technical components paid at 50%. So essentially what this means is that there is individual cascading reductions applied to both the professional and the technical components of the codes. Basically what we're trying to state here is that this stuff is complicated. It's really important to either have a really firm understanding of it or leverage technology to help you. So this is the last thing I'm going to cover today. I know we're starting to run a little bit over, so I'm going to try to get through this as quickly as possible to get you back on your day. But I want to look at the second bill review process quickly. Second bill reviews are more important than ever. The reimbursement has increased for a lot of codes, including evaluation and management codes. So providers, if dates of service on or after March 1st are paid at the old rates, it's really important that you submit a second bill review to request additional money per the fee schedule. These short payments should be always analyzed and submitted back to the carrier so you can get those payments in the door. This particular bill is an actual real bill from one of our providers. It's for a March 6th date of service, and it was affected by that 6% increase. And on the original bill, State Fund paid the old rates for both the E&M code, 99214, as well as the WC002. The provider submitted a second bill review stating that the fee schedule changed as of 3/1 and that the new amount was due per the OMFS for this date of service. And then SCIF paid an additional $10.38 that was due for that date of service. And without an SBR, the incorrect processing would have saved SCIF 6% and cost the provider in lost revenue. And there are just so many bills out there that are not getting paid properly, so it's really important to analyze those. Here's another example of a CNA that's paying the old rate for the WC002. And we can't think of a reason why CNA is not paying this code correctly. So it's just really important that everyone submits these second bill reviews so that they know that providers are not going to put up with this. And then finally, here's a date of service for April 16th, 2015. Gallagher Bassett was continuing to reimburse the WC002 at the old amount. The reimbursement was over 45 days after the increase in the OMFS. And Gallagher obviously knows that the fee schedule changed because they're paying some of the other codes, the 99214 and the 72100. But we think that they're just trying to sneak that by providers and not pay them that extra money. So we've been focused on the changes effective March 1st, but remember, as I just mentioned, changes are constantly happening. There are weekly changes to the dispensed pharmaceutical fee schedule and then monthly changes to multiple aspects of the fee schedule at large. And then take a look at this screen. This is the changes that have taken place since March 1st. Lots and lots of changes here, so it's really critical that everybody stay up to date on these things. And then on June 11th, this was last week, the DWC announced that it was adopting the new Medicare RVU 15C file for dates of service as of July 1st. So this is yet another update that you'll need to keep up to date on. So starting July 1st, in order to calculate the reimbursements as well as the MPPRs, and that's the multiple procedure reductions, the RVUs and the multiple procedure values need to be taken from this new Medicare file. And again, that's the RVU 15C. So in these last, 30 or 40 seconds as a final wrap up before we answer a few questions, there are just 3 things that I want to review. So the first thing is that, and I stated this at the beginning, that effective January 1st back in 2014, there is not a published fee schedule. You need to make these calculations on your own or find a resource that will make these calculations. The second thing is that the fee schedule is not 120% of Medicare. I talk to people all day long, at least once or twice a week. I talk to people who still think that you can just take the Medicare rate and multiply it by 1.2. This is not correct. You have to have all those components, the GAFs, the RVUs, and the conversion factors in order to properly calculate the reimbursement rate. And I just want to mention that we also have a toolbox. We are offering 50% off the monthly fee for Physician Partners members. So if you have any questions about the toolbox or want to find out how it can help you create effective RFAs, easy second bill reviews, and then do all of these calculations by any date of service, reach out to me. And again, we're offering a 50% discount off the monthly fee for all of you members. So with that, I just want to thank you for joining us today. I've put my email and my phone number on this screen. So if you have any questions after the webinar or in the future, please don't hesitate to reach out to me. We here at Daisy are here to help. So I really want you to reach out to me if you have any questions regarding today's webinar or any other issues in workers' compensation. So with that, I'll turn it back over to you, Veronica, and we can maybe get to a few questions.
Thank you very much, Sarah. I appreciate your information there. I want to let everybody know that this webinar was recorded, so we will have a recording available on the Physician Resource Center website. The slides will be emailed to everybody as well. And we do have a question that came through, and the question is, we have some workers' comp adjusters who pre-authorize medical record review of 99358, but then the bill review won't pay for it. Is it true that 99358 is payable if separately authorized in writing?
Yes, that is true. So there is a section of the Labor Code. It's section 5307.11. And everyone should write that down. What that section of the Labor Code states is that a claims administrator and a provider or a provider's representative are allowed to engage in an agreement that supersedes the fee schedule. So let's say that the claims administrator or the adjuster wants the provider to review a big stack of records, and the provider says, I need to get paid for this. The claims administrator is allowed to agree to pay the provider, and that overrides any fee schedule rules. But here's the key. You as a provider need to get that agreement in writing, and it needs to have certain components. It needs to have what is being agreed to, record review, what code is going to be used, and that can be the 99358, and here's possibly the most important thing, what is going to be the rate of reimbursement. So have all three of those components in addition to a signature from someone at the claims administrator. And then once that's signed and once you perform whatever the services are, record review, or anything else that you're having an agreement with the claims administrator for, submit that signed agreement with the bill. Because if bill review doesn't have that agreement, they don't have any way to know that there is an agreement or a contract that supersedes the fee schedule. So have it in writing, have it signed, and submit that with the bill. And we actually have a section on our website. It's a little buried in our website, so you can feel free to shoot me an email, and I can send you a link to some tips and tools and suggestions. We even have a template that you can use to submit an agreement per 530711. So feel free to email me if you would like a link to that.
Great, thank you. It appears that only one question has come through, so I'll go ahead and review the poll question and answers. And here is the first question. Are you aware of the California Workers' Comp fee schedule change effective March 1st? It looks like 43% answered yes and 57% answered no. Is there anything you'd like to touch on this, Sarah?
This doesn't surprise me. I know that it's very hard to keep up with a lot of these fee schedule changes, and most people I talk to are either aware there was a change but don't know what it was, or just not aware of the changes. So also feel free to subscribe to our website because we send out free emails when these things are changing. So we want everyone to be aware of these changes. The key here, and I kind of touched on this at the end of the webinar, is that a lot of these codes increased. So that's good news for you. But the bad news is a lot of those claims administrators aren't paying those increased rates unless you're submitting a second bill review. So you have to not only know those rates, but also know if you're getting paid correctly. So certainly find out when those fee schedules are changing, and we can help you with that.
Wonderful. Let's go to the second question, and that is, how do you currently track the California fee schedules? It looks like the larger I don't track the fee schedule is 42%. After that, 33% answered unsure, 17% answered another fee schedule calculator, and then we have 8% that answered manual calculation. Would you like to touch on that?
For the people that don't track the fee schedule and are unsure, find a way to do it. Whether you use manual calculation, you can reach out to us, we can help you. You know, there are a lot of different ways to do this, but I just can't stress enough how important it is. Lots and lots of lost revenue is being left on the table. Just in the second half of 2014, our providers collected over $3 million in payments on second bill reviews. So there is a tremendous amount of money being left on the table. You can increase your revenue by tracking this stuff.
Looks like two questions have come through. First question is, Are we allowed to bill the office visit 99213 through 99215 along with WC002 or WC003?
Yeah, the WC, yes, you can bill an E&M code with a report. The WC002 is the PR2 report. So those of you that are more familiar with the old fee schedule, that code was the 99081. But yes, absolutely, you're allowed to bill it with a report code. WC003 is a permanent stationary report, but it's for a date of service with a date of injury 2005 or before. More typical now is the WC004, which is the permanent stationary report for dates of service 2005 and forward. And feel free to reach out to me if you want some information about that. But absolutely, both of those codes are reimbursable.
Okay, another question is, what is the correct WC code for supplemental report?
There isn't one. So there is the old code was a 99080. There is no reimbursement for a code unless it's on the WC, the California specific regulations. If it's not on there and you want to get paid for it, you would have to engage in agreement per Labor Code 530711 that I stated before. We have a lot of suggestions for how you can deal with that, including refusing to do some of these supplemental reports that are not mandated per the work comp regulations and the work comp rules. But again, feel free to reach out to me. It's kind of a longer discussion that we don't quite have time for today, but I'm happy to help you with that.
Great, thank you. And we have one last question here, and we'll go ahead and conclude today's webinar. Question is, if and when does interest accrue for work comp carriers who are not paying claims?
So it accrues at day 45. That's when the time starts ticking. Keep in mind that you can't calculate the full penalty and interest until you've actually received payment. You can calculate the penalty because it's a straight 10%, but you can't calculate the interest because it is based on how late they are with the payment. And one additional thing, this wasn't in the question, but how do you bill for penalties and interest? It's supposed to be self-executing, so there is no procedure code for penalty and interest. So what we suggest to our providers is submitting a second bill review for penalties and interest once you receive the payment. And again, if you have questions about how to specifically do that, feel free to reach out to me. But the key here is that you have to do a compliant second bill review in order to get that penalties and interest if it's not self-executing. I only know of one carrier right now, Skiff, who is automatically applying penalties and interest, self-executing penalties and interest. I've seen it on a few other carriers occasionally, but not with the frequency that it should. So reach out to me if you would like to discuss penalties and interest in more detail.
Thank you very much, Sarah. I really appreciate the webinar today. It was very, very useful. I hope everyone who participated felt the same. Again, if you have additional questions for Sarah, please note her email and her phone number on the screen. Again, the slides will be emailed to you as well, so you'll also have her information from the slides. And again, thank you very much, everyone, for participating today.